some questions my patients ask me, and I'm sure they're questions your patients ask you. And there are basically 3 or 4 of them this morning. One of them, they say to me, I'm exercising, I'm eating properly, I'm not losing weight. Why is that? Oh gosh, I guess you've heard that one. Well, okay, we'll take a look at some things today. The other one, I think probably the one that is brand new this year, is people say to me, gosh, you know, yes, I have this osteoporosis or this osteopenia, and I don't want to take anything for it. And I can agree with that. They say, I want to use the calcium, vitamin D, I got that part. What about exercise for my bones? So as we finish up here today, we're going to look, I looked through all the exercise literature. Boy, that can cause a lot of sleepiness. And many of these are not good studies, but I found several, mostly in Europe, excellent studies. We'll take a look at those. Okay, there are no disclosures for this. Nobody cares to pay for this sort of thing. And I'm just going to let you look at this BMI chart. Sometimes it's a shock. Sometimes it isn't. Take a look here. See where you fall on this chart. Okay. Okay, we talked about the obesity guidelines. Very important to remember, we cannot reduce everyone. Oh goodness, so many people in the United States are overweight. 69% of us are overweight. We're not going to fix that whole thing, but do focus on the people with metabolic syndrome, the people who have problems that you're going to help solve by weight loss. And that's probably the most important part of this guideline. Now, we talked about obesity, and certainly it's going up. The prevalence of self-reported obesity is going up as well. I think that's kind of interesting. We even are now admitting here over 2012 to 2013 that we're getting more obese. But as we said, we really don't know how much, what extent the obesity epidemic is in the United States, because it's now all self-reported. And as we looked at the other day, people tend to underreport, not because they're schmucks, but basically because many of us, most of us, don't know how tall we are. We really don't. You know, we know how tall we were in the 5th grade. I was 5 feet 4 and a half. I think I probably shrunk a little. And so, you know, we just don't know. And if you ask 10 people how much they weigh and then weigh them, 50% of those people will be really off by 5 or 6 pounds. So we don't know how much we weigh and we don't know how tall we are. So the person whose idea it was to call people on the phone and ask them should be taken out and shot. Okay, causes of obesity. Well, in 2010, the CDC told us that we eat too much and we don't exercise enough. And that's why we're all obese. Well, to an extent, I guess they're right. But there are some other causes, and we're going to take a look this morning because there are some new ones. Heredity, we know. Environment, oh, there's some new ones there. An unhealthy lifestyle, well, yeah, that's us. But if you look at heredity, look at the white non-Hispanic, 32.6% obese. These figures are from 2012. They're our latest ethnic figures. If we look at Hispanic, 42.5. Black non-Hispanic, 47.8. Asian, 30.3. Definitely a hereditary predisposition. And if you look at the Hispanic and the black non-Hispanic, many of those people have insulin resistance. They're born with it. So they're behind the 8 ball from the time they're born, and helping in the mother while she's pregnant to not become overweight, helping that mother not to develop gestational diabetes. Big help there with obesity in the fetus, obesity in the baby, and then obesity in the child and adult. We know that if you pop out of the womb obese, our chances of really getting you to be thin in later life are poor. If you're an obese child, you have a 90% chance of being an extremely obese adult. So again, it's all the way up the ladder that we kind of have to work on things. And I'd urge you, when you take care of your pregnant patients, please try your best to prevent them from having gestational diabetes, because that has a real impact on the rest of your life. How about environment? And you say, I'm looking at this. I know this stuff. I know that if you can't get to the park because it's unsafe, if there are drug dealers on the playground, then people aren't going to go. They're not going to exercise. They're not going to risk their lives to walk around the block if there's a problem with safety on the block. Communities where you can walk to the store, where you can walk to work, are designed communities. They're few and far between, but the people in them are actually statistically significantly thinner without instituting a lot of obesity programs for them. In Europe, the people are thinner because they bike and they walk places. And I have to tell you that I was recently when I was in Denmark, I took a walk. And I stopped at a stoplight. It was a big intersection. I look around, 50% of the people at that stoplight were either walking or biking. Take any big city in the United States, pull up to a stoplight in your car, which you'll be in, look around you. Is there anyone walking? Or no. So they walk a lot more. They are quite a bit thinner. Workplaces encourage employees to use stairs, to park further away, just simple things. Those employees do better. And I tell my patients when they say, oh gosh, I just can't get it off, it's still here, I keep it, okay. Then look at these things, particularly at your workplace, because a lot of places have incentives. Ours does. If you lose 10 pounds in 6 months, they give you bonus points. And if you get 4,000 bonus points, you can get a new stopper for your bathtub or something. I mean, this is not a really overwhelming program, but it at least gives you some incentive. My secretary, who's really thin, has lost 10 pounds every quarter and has actually gotten something reasonable, like a new suitcase, I think. She gains it back in between. So there are ways to circumvent this program. But, truly, the environment we live in frequently has opportunities for us to lose weight. But I want to talk this morning for a few minutes about endocrine disrupting chemicals. The Endocrine Society says whenever we talk about anything, anywhere, we ought to kind of sneak this in because they are true. And Britain is way ahead of us. The United Kingdom now says that about 50% of their obesity and diabetes is secondary to these endocrine disrupting chemicals. And you know them from the past. Diethylstilbestrol was probably the first, or DDT. Those were endocrine disruptors. They caused infertility. They led to cancer. So the endocrine disrupting chemicals have been with us for a long time, but not in the profusion where they are now, because now they're found universally in plastics and cosmetics. They're coatings for pills. Some of your extended release pills are actually coated with plastic to make them that way. And the phthalates and plastics have a 50% plus probability of causing obesity and diabetes. They disrupt ovarian function, but they're everywhere. And so when we speak, the Endocrine Society says, look, the two biggest things, the two biggest encounters with these endocrine disrupting chemicals are, I'll write this down, microwaving plastic containers. They said, tell yourself and your patients not to heat anything in the microwave in a plastic container. Use glass, piece of Corningware, Pyrex dish, a paper towel, but don't use plastic containers. And they say that all of our fast little meals come in plastic containers. Stouffer's is now putting theirs in cardboard containers. Unfortunately, they coat those with plastic and put a plastic wrap off of the top. So they suggest you just get them out, throw away the whole container, put them in some sort of a glass receptacle and microwave them in there. Don't microwave them for 40 minutes on high in this big plastic container because the phthalates leach out and they go into you. The other place they're saying is water bottles. Now, everybody's going to look at their water bottle, but they say that if you use water bottles with a recycle number of 3, 5, or 7, they're more likely to have high concentrations of phthalates than the other numbered bottles. Don't ever leave your water bottle where it's hot because the phthalates leach out, and what happens is you take off the top and drink a big bunch of endocrine disruptors. So they think if we are careful, particularly with our children and our grandchildren, that we will have less obesity in the future. And the British are banking on that. They're putting in laws about the amount of phthalates you can have in your plastic water bottle. So that's one of the things. However, we're pretty naive if we think we take the metabolic syndrome patient with the 48-ounce cup of sugar-sweetened beverage and put it in a paper cup. You think that's going to help? No. So I think we have to be just a little careful about our thoughts of the impact of endocrine disruptors, particularly in the United States, where we don't have compulsory walking, compulsory bike riding to get around our cities. Well, the biggest thing, unfortunately, is unhealthy lifestyle. We own more exercise equipment than any other country in the world, but we don't use it for exercise. This is Lucky the cat. She's taken her string here, you can see, and she is headed for her favorite sun patch to curl up with the string instead of exercising with it. Our biggest problem, though, is portion control. We've talked about that before. This meal that the little girl has is actually an adult-sized portion. And they did a study in the lower middle schools, like 4th, 5th, 6th grade, and they said, okay, kids, what is a portion in this lunch line? And the children had no clue. But we said, okay, they're kids. The real problem was the people actually serving the lunches and monitoring the lunches had no clue about what a childhood portion is. When I spoke to the Head Start people, we talked about the peanut butter serving for a 3-year-old child, which happens to be a tablespoon if that's their protein for lunch. That's a very nice protein, and this is a poor area. So they used a lot of peanut butter. And I said a nice tablespoon. The lady said, if we only fed them that, they'd starve. No, if we only fed them that, they wouldn't be overweight. So again, CDC has a lot of good things for kids, like rethink your drink and fiber is your friend. So tell your patients, go on that website, cdc.gov, a lot of nice info for parents and children. Sugar-sweetened beverages. Again, even in a paper cup, these are not good for you. And what they do, interestingly this year again, you heard about the biome. I think last year Dr. Martins told you about the biome, your own little bacteria that help you think and help your gut. Well, it turns out if you eat sugar-sweetened beverages and high-fat food for 2 weeks in a row, you are now colonized with very interesting bacteria. And they've done studies where they did endoscopy and looked at the bacteria in the gut. It turns out that you are then colonized by bacteria that are very efficient at getting calories out of your food. They have enzymes that are much better than your pancreatic enzymes, and they ooch calories out of high-fiber squash. I mean, they really give you many more calories than you would have gotten on your own. And there are just so many of those little suckers. So again, we need to eat, if we eat a healthful diet for about a month, our gut flora is a lot less efficient at getting calories out of our leftover food after the pancreatic enzymes are done. So another reason to eat that spinach. We all know the medical complications of obesity. Remember that new ones are that you can have secondary hyperparathyroidism. And obese people, as we saw, type 2 diabetes, people with sleep apnea and obesity are more likely to get osteoporosis. You know the classical ones. I don't think we have to go over those again. Well, we said the other day that pharmacotherapy has risen to the top of the tiny pyramid because of the problems with weight reduction drugs, and surgery has come down to the middle. But today we're going to talk about the bottom part of the pyramid, and it will always be the bottom part because we can't really afford for all of society to have bariatric surgery. When you look at nutritional therapy with your patients, be realistic. They're only going to lose about 5% on average of their body weight. And if you look at this, this is a graph from a psychology journal, and people think that, oh, their weight loss goal here, they like to lose about 20% of their weight. This would be really good, right? If I were 200 pounds, I'd lose 40 pounds. I'd be able to be in a diet soda commercial. Okay, now then, acceptable. Well, you know, if I could lose about, maybe 30% of my excess body weight, I'd feel pretty happy, right? Down here, when you're talking about 5 to 10%, this is the horribly disappointing weight loss. I mean, here we were happy, there we thought we were okay. Disappointing is about 20%, 10 to 20% for most people, and that's probably all even the most assertive people are going to achieve. Right down here where we're looking at 5 and 10%, it's not even worth the effort to a lot of our patients if they come into our office with the wrong mindset. So the first day when people come to my office and say, why can't I lose weight? We discuss that 5 to 10% is all that I can do for you. We may be able to ooch out 15 if you're very proactive. 20 is practically impossible. And I go over that very carefully, and we talk to them about that because otherwise they're just never going to make it. Well, what's new? Interestingly, new is that it doesn't matter what the macronutrient disposition is. You want a high-fat diet, I can provide that. It's polyunsaturated and monounsaturated fats. There still aren't many saturated fats. Remember, he who eats saturated fats gets bacteria that give them more calories. If you want now, we feed the food we eat a lot of interesting things. And we're feeding a lot of things, omega-3 fatty acids. Catfish, for example. My patients say, if I could just have a cat, go right ahead, have catfish. Make sure it has omega-3 fatty acids in it. Go right ahead, eat eggs with omega-3 fatty acids. Be happy. Use canola oil that's going to be genetically altered. The plants are genetically altered to make more omega-3 fatty acids. So pretty soon we're going to be able to eat a little more liberally, and the things we eat will have already been provided with omega-3 fatty acids. So my patient said, well, let me tell you, better the catfish eat that stuff than me. So again, he's going to get it in, though, because the catfish are going to eat it first. And we know from this really fairly old study in 2005, it doesn't matter what you eat as long as you eat a whole heck of a lot less. Some people had Atkins, some people had Weight Watchers, Ornish, and Zone. They're very different in terms of macronutrient disposition. Atkins is high fat, Weight Watchers is medium fat, Ornish is no fat, and Zone is fat, but you move it around in the week. So again, there was no difference in anything, including the weight loss. So it doesn't matter what you eat as long as you eat less of it. Okay, so what's our initial therapy? I tell people, if you want to lose weight, you've got to eliminate the concentrated sweets. They're concentrated calories. The saturated fats, they're concentrated calories. And substitute monounsaturated or low fat. The carbs, 130 grams of carbs a day is probably the maximum you're going to eat if you're going to lose any weight. And you're going to add a lot of fiber and a lot of no-calorie fluid. Those are two of the most important things you're going to do. And this is Corky the dog eating his high-fiber bone, but fiber is incredibly important. It decreases constipation. It decreases hunger. And the other thing that's incredibly important, Lucky the cat, is drinking her water. Hydration, at least. You know those glasses of water you always see on the internet when you're looking about how to lose weight? You got to have them because they keep you hydrated so you're not constipated when you're munching on your celery stalk. Okay, where are you going to get that info? Again, cdc.gov is one of the best places to get it. So go to that website, have your patients go to that website. Really is an excellent website. Tells you all you need to know about healthy eating. It truly does. Or use an app. MyFitnessPal is really good. It used to be free. I think now it's a nominal charge. But again, you have to put your calories in or it reminds you. You have to put your exercise in or it reminds you. And it calculates for you by the end of the day what you need to do for exercise at bedtime. My patient said, this is impossible. I said, well, did you exercise during the day? She said, no, it told me I had to walk 2 hours at midnight. Well, you know, if you'd done it before, it wouldn't have told you that. So I tell them, your phone is a partner to improve your health. And I tell them that because by the end of your visit, I'm fed up with your phone ringing in my office. So again, I mean, This is a nice meta-analysis, and meta-analysis usually put me to sleep. But this one looked at all the diets from 1957 to 2013. Just think of the number we've seen in that time. And they said the Mediterranean diet is the best one. It has the best proof. It has the best literature. It can decrease the incidence of malignancy and cardiovascular disease. And it's one of the simplest to use. So if your patient wants a name, the Mediterranean diet is the name. Look at this. It actually reduced cardiovascular risk to the same degree as statins. Those of you who didn't want your patients on a statin, you don't want to be on a statin, try the Mediterranean diet. The other thing people ask me is this diet okay? You know, can I use this diet? And it's usually these 3 books or these 150 pages on the internet. So these are the questions, and I tell the patient, go, look it up. So when you look at your diet, these are the questions. Is it low in saturated fat? Does it have some monounsaturated fat source like nuts or high fiber vegetables? Does it have adequate fiber? Does it have enough carbohydrates and fluids for your patients with diabetes, enough hydration, and most important, does it have enough protein? People I see on diets they've made up or gotten off the internet, frequently there's low protein in these diets. You don't want that. You'll lose muscle mass. So this is the slide. I print it out and I say, figure it out. And come back and tell me what you found. Okay, I did the Paleolithic diet in your handout, by the way, and I showed you how it fits these guidelines. And it does. Attitude toward exercise, the art of converting big meals and fattening snacks into back strains and pulled muscles by lifting heavy things that don't need to be moved and running when no one is chasing you. That's the thought I have about exercise every day when I go out for my walk. Okay, so and I told you about how to get people exercising in your handout. But as we end up, I wanted to talk about that last question, what does exercise do for my bones? And this is one of the best studies ever done on exercise. It was done in the Scandinavian countries where they have socialized medicine, so we're all in the crowd in the Scandinavian countries. They can look back, they can look forward, they can do studies. And this is the effect of exercise on fracture rate and bone mineral density in early postmenopausal women followed for 12 years. So remember, at menopause, you can lose a lot of bone, like about 4% a year if I don't stop it. Calcium and vitamin D slow that down to about 2 to 3% a year in most women. By about 5 to 8 years, they no longer lose bone at that menopausal rate. They lose it at about 1% a year. So this covered the whole spectrum. And it asked, can we decrease the risk of menopause on fracture and bone density loss? And the treated group had 4 exercise sessions a week. And you went. 2 were in the gym. If you didn't go, they went to your house and brought you back. 2 were in your home with a trainer provided by the study. So you exercised 4 times a week. What kind of exercises? Mostly mobility, balance, mild muscle strengthening. Well, just very small weights, very small squats, things like Tai Chi and yoga. Okay, so this wasn't running around the block, okay? The control group were told to maintain their activities. But this was Scandinavia, where I told you, 50% of the people at the stoplight are under their own power, okay? So they looked at low trauma fractures, fragility fractures, and bone mineral density. The relative risk of fracture in the treated group was 0.51. That is amazing. Almost a 50% decrease in fracture rate in the people who exercised. And these other people were not couch potatoes. They were just, ordinary folk. Bone mineral density still decreases, but less in the exercise group, statistically significantly less, but you did not prevent the bone loss of menopause by exercising. You helped stabilize it after you get to be about 5 years out from menopause. They didn't lose very much. They became very much like men. Muscle mass determined their bone mineral density loss. So that's good. That's the best study. It just finished this May. They just rounded up their data. So that's probably one of the best studies ever done. Oh, yes, you can build bone mineral density. If you're a teenager, you play tennis, you develop more bone mineral density in your dominant arm. So to code that, you'd say right dominant arm. Just get in there. Okay. Now, how about exercise decreasing the risk of fracture in older women? Yes, this was another large study published in the Journal of Bone Mineral Research in 2011. It was a randomized prospective controlled study, so that was very good. They looked at hip fracture in postmenopausal women. They said any form of consistent exercise, that was walking, mobility, and balance exercises, again, Tai Chi, yoga. They had some people who jumped rope, some people who jogged. Strenuous versus non-strenuous, no difference. If you got it up and got going, then you had fewer fractures. And finally, this one was an interesting study because it looked, it's very recent, looked at 70 to 80-year-old women. Okay, these are people who are not young. And they had 4 groups: exercise plus vitamin D, exercise no vitamin D, no exercise plus D, and no exercise no D, the 4 obvious. The endpoints were falls, muscle strength, balance, mobility, bone density, and D levels. Well, people took their D. But look at this. Look at the fall rate. Oh, how disappointing. They fell down just as much, okay? But look at the injuries and fractures. Look at the difference. If you have exercise plus D, 6.5 compared to 118 times they fell down, only 6.5 did they have significant injuries. 132 times they fell down, 5 injuries, 5 falls with injuries. Look at the difference with injurious falls if you have exercise on board. You have more muscle mass, you have better balance, you have better mobility. When you fall down, you don't break it. You know who falls down most? Women fall down more than men. I've got that. You know who falls down most? Kids. Do they break stuff? No. They have good balance, they have good mobility, they have some muscle mass. And so that's what we're doing here. If you look at the no exercise, with or without D, again, lots of falls, more injuries. So there you have it. The bone mineral density declined in all those groups. The spines were stable after about 5 years in the postmenopausal group. In the other study, in this case, we're all postmenopausal. We're all losing bone at about the same rate. And exercise doesn't prevent falls, but it prevents injuries from them. It doesn't really stop decline in the femoral necks, helps decline in the spine, and both D and exercise decreased bone loss. So that's it, and that's your food plan and your exercise program for life. Okay, thank you.